Thank you, Brooke, and welcome everyone. Good afternoon. We'll start out today talking a little bit about what's happening and why, and then maybe the second half we'll talk more about what to do about it. But this first slide I call the Balkanization of provider revenue. And what do I mean by Balkanization? It's basically the disorderly fragmentation. So if you see at the top the traditional scale and sources of revenue, and then below the provider expenses, I've provided 5 kind of pillars or disruptors of this ecosystem, if you will. And by ecosystem, what I mean is that generally in healthcare, provider revenues and expenses are generally about the same, very small margin business, could be 1% if you're doing really well, maybe 4% operating margin. But the reason for the red is to say that these revenues are being balkanized or disrupted by these 5 factors below. So whether it's the ways that revenue is created, inpatient, outpatient, physician, or the ways to lever it, whether it's volume, mix, or rate, these things are all being impacted. And I'm going to cover the insurers and the commercial and price transparency later. But the economy right now, because of COVID-19, so we know how volumes have been impacted and volumes have moved to telehealth. And what does that mean for the future? And in general, elective procedures are substantially down. We know the economy has been impacted with unemployment. That has impacted payer mix. Government programs are increasing as our population ages and more people move from commercial insurance to Medicare. But also plan design. With higher unemployment, the basically power has shifted to employers. And so you're starting to see plan design, which is much more restrictive now with the introduction and increasing use of HMOs and EPOs and high deductible plans. So that means that employers basically are pushing their employees to lower cost sites of care. In terms of the government, CMS and the Biden administration, we expect to see much more in terms of value-based care and bundles, and also more restriction on M&A. So if M&A was one of your growth vehicles, that could be constricted as well. But what happens when that provider revenue shrinks? And so we saw that from COVID, and if we see that in the future from all these disruptors, what happens to expenses? So as revenues are squeezed and expenses are squeezed as well, there is a fixed cost element to those provider expenses. So I've pegged this at around 30% variable costs, and in a regular provider, about 70% of your costs are fixed no matter what the volumes are. So as those revenues are squeezed, it's very hard to reduce those fixed cost expenses. So this creates a real problem in terms of profitability. And we saw that with the impact of COVID-19, but also into the future with all these disruptors that we're seeing. So this next slide, say hello to the competition. So the competition isn't necessarily the hospital or health system next door to you or down the street or in the city or in the suburbs. These are the new competitors. They're well-funded, they are narrowly focused, they're consumer-centric. And it could be the large insurers like United, like CVS Aetna, Humana, but it's also those that are retailers like Amazon and Walmart. Amazon, who already has a massive distribution network, Walmart, which has geography all over the country. These are your new competitors. There are also private equity funded organizations, IPOs like Clover Health, ChenMed, Oscar, where they're looking at very narrow opportunities to take a piece of your business as a provider and move it over into their domain and do it theoretically more effectively at a lower cost point and in a more consumer-centric way. So these are formidable competitors that you now have as a provider. One way to demonstrate this, and this is a great slide from, there is a weekly blog that's put out called Gist Healthcare. I'd recommend any of you to subscribe to it. It's free. It's done by Chaz Rhodes, formerly of the advisory board. So every week they have a newsletter that comes out and also a great visual that accompanies. And this is one where just to get a sense for the scale of the competition. Providers are dwarfed by the competitors in this marketplace. So you see to the left, the pharmacy and retail, we're talking between 250 and 500 billion in annual revenues. And compare that to the far right, when you look at even the largest providers like Kaiser, HCA, are 50, 25 billion, let alone most what I'll call normal providers, regional providers. They may be 5 billion, 10 billion, 2 billion, and even less. So to think that you're going to compete against these new entrants in terms of resources and investments, very, very difficult. And you can see what's happened during the last 2 years, during the time of COVID. The growth numbers, they've grown. Pharmacy retail 16%, insurers have grown 9%. Well, what's happened with providers and with health systems? They've actually shrunk. So you see the revenue actually decreased 3%, primarily in the outpatient space, down about 6%. So very, very difficult competitive landscape. So insurers are actually no longer insurers. They have what I call insourced healthcare. They're now completely vertically integrated. They're not only insurers, but they have PBM capabilities, they have specialty pharmacy capabilities, and they are now providers. So whether that's Aetna with CVS, United, actually Optum is the largest employer of physicians in the country. Anthem, I'll give you an example. On an investor call 2 weeks ago, they talked about their diversified business group and chronic care. About 7% of their chronic care today is provided by their owned providers, and they're forecasting that's going to grow to 25% by 2025. So a quarter of their chronic care is going to be done in-house. And that's coming directly away from traditional providers. So you can see this landscape is a very, very difficult one. They are all completely vertically integrated. They're no longer payers, they are payer providers. So how do the insurers view the world? They view the world as a massive opportunity. And this slide is a typical Medicare Advantage member. For example, let's say on a $100 monthly spend per member, about 31% or $31 of the 100 is spent on inpatient care. The outpatients about 14%, and physicians about 17%. So about 62% of the monthly annual medical spend on a Medicare Advantage member is provided by traditional or core hospital services. So that is a massive opportunity for the insurers to reduce, to reallocate, and to redirect that spend to their owned assets. So think of the tactics that they will utilize. The traditional tactics are around network value, so they'll continue to negotiate for lower rates and try to find lower rate providers. They're always looking to utilization, who actually utilizes less, more in tune with Milliman standards. So they're looking for the overutilizers in that fee-for-service environment. And then, of course, who has the best outcomes. But also now the ability to reallocate and divert that spend, that 31% of inpatient spend. How do I redirect that to the outpatient environment or to the physician's office? Or how do I redirect it to my owned assets, to the things that the insurance company owns, instead of those ones that are traditionally provided by providers? So this is a new threat and a new risk to traditional providers. Also, I mentioned earlier about plan design. How do you create more narrow networks with lower rates and better outcomes and lower utilization? And then also it changes the role of the physician. So physicians have traditionally been seen as creating referrals and a pipeline for the inpatient business. But now physicians that are employed by insurers are viewed as gatekeepers. They're viewed as delivering wellness instead of delivering referrals. So this is a new world that we're living in. It is a world that I believe will be dominated by the insurers. And this is how they view the world. Price transparency is another threat that is new. What you see here is a quote from Judge David Tatel, and this was when the AHA was arguing against the implementation of price transparency. And so one of the lawyers from the AHA was trying to explain why it was impossible to list prices. And the judge simply replied, why is the price of the x-ray unknowable? So something that seems normal to us in the provider space seems completely illogical to the consumer and to, in this case, the court system. So as you know, that price transparency legislation was introduced at the beginning of the year. So the question is, will you address it as a system? Many are delaying their implementation. They are refusing to disclose their prices, or they're doing it in a way which is difficult to understand or for the consumers to see. But if you think of what's happening, and to the right, you see some of the examples of what's been disclosed through this price transparency. And this is no slight to any of the ones that are listed here. This is simply an article from Healthcare Dive, which introduced some of the data that they were able to mine. And you see the tremendous variability, and this is for a joint replacement, not only within the same hospitals, depending on the minimum price or the maximum price that they charge for the same procedure, but also between different systems in different parts of the country. Why did this happen? Well, we had a bundled system where prices were negotiated in bundles, or they were negotiated as part of a market basket. Now we're being asked to justify them on an a la carte basis. So this sort of irrational pricing led to irrational costs, and we're going to cover that in a minute. But the opportunity here is to think about your services as premium services. Where do you have very high quality? Where do you have a reputation for a specific modality or a specific type of care? And then what is the scarcity? Is it a type of care or a type of procedure that can only be done at your hospital or at very few hospitals? Those are areas that are premium services and where you can raise prices versus something that's considered a commodity where lower prices are demanded. So this creates what I call this fee-for-service circle of doom. And what do I mean by that? Again, this irrational pricing came about because of bundled pricing. It came about because of market basket pricing. So providers were negotiating with payers on the entire bundle of activity, not on these individual specific procedures. So what did that do? It gave us very irrational prices for many different procedures. It also created what I call the golden goose phenomenon, where you have some very low value types of care or things that are considered commodities. Imaging would be an example, with very high reimbursement. So that's created a situation where you have a golden goose. We have something that is very high priced, that has become a commodity service. So the struggle that you have is, do you lower the prices to become more consumer competitive at the risk of reducing your profits? So it's a real quandary that you face. Eventually, those prices will become commoditized and those prices will go down. Also with new technology, very difficult to price new technology effectively. I'll give you the example when TAVR procedures were initially implemented, the reimbursement for them, basically 100% of the reimbursement went to the supplier for the actual implant, and nothing was left for the providers to pay for, not only the staff and the labor, but also the overhead of actually doing the TAVR procedure. So sometimes on these new technologies, we don't have the ability to rationally price them. Inflation, always in excess of CPI. So we've never been able to pace healthcare inflation with the overall growth of the economy and the overall inflation. So this whole irrational pricing was a great strategy when we were all making profits as a provider, until it's not. Now that, and with COVID, now that we're having systems that are actually unprofitable or losing money, very difficult now to continue this strategy when it's no longer working, and we need rational pricing, and we need the ability to transform our cost structure. And then finally, we see we're moving away from fee-for-service healthcare. So that's where we all were 10 and 15 years ago, and we're all now being forced to move to the right, which is towards pay for performance, for episodic payments, or also even for full capitation. So this is the new environment, and it's moving away from fee-for-service. So with that, we're going to have our first poll question, Brooke.
Thanks, Rob. All right, I'll go ahead and launch our first poll question. So we would like to know, when do you predict a return to normal? And we're talking about pre-pandemic hospital volumes and revenues. So your options are 2021, 2022, after 2023, or permanently altered and changed. So we'll give you a few seconds to get your votes in. It's like we're getting quite a few votes. Thanks everyone for participating. Give you a couple more seconds. Looks like our votes are starting to level off, and I will go ahead and close that poll and share the results.
Brooke, I was unable to see the poll. Can you sort of tell me what the consensus was?
Yeah, I'm sharing the results right now. So our biggest response was 59% said it's been permanently altered and changed. And the next closest response was 24% said 2022, 14% said after 2023, and only 3% said 2021.
Great. So I don't have much convincing to do then. That's great to hear that. I think the audience is of the same mindset that things have changed permanently, and COVID has maybe opened this up. But in terms of things getting back to normal, I don't know that that's ever going to happen. So that leads us to the next discussion, which is what to do about it. And so when you think about healthcare versus every other industry, and I came into healthcare from industry. I was with GE. I was actually in the locomotive division. And the point of this slide is that with Six Sigma methodologies, every part, every component of a locomotive it went through very thoughtful and rigorous engineering. Any changes that were made had to have scientific evidence, basically, in terms of efficacy, both cost and quality, before a change would be made. So very structured. You come into healthcare, though, and what I was told was, look, healthcare is not manufacturing. It's much more important, and the stakes are much, much higher. But what I would tell you is that exactly, the stakes are much higher. These are our loved ones that we're talking about. So in terms of the engineering that goes around clinical pathways, we absolutely need that same level of rigor around clinical pathways in the delivery of healthcare. So I don't give a free pass to healthcare. In fact, I raise the bar even higher. So where did we get to where we are with cost systems in healthcare? I'd say about 95% of systems today use either RVU-based or ratio of cost to charge-based costing systems. And these are revenue-based systems that were developed 20, 30, 40 years ago. And I don't know that they ever made sense, but the context was around standalone hospitals. There weren't really large systems back then. You were trying to understand within the walls of a hospital. Let's say if you had $100 of profit, or $100,000, let's say, of profit in that health system. It was done by the finance teams to try to understand, well, what's driving that $100,000 of profit? Can we get a general sense? Is it coming from cancer care? Is it coming from our orthopedic practice? Is it coming from behavioral health, from pediatrics? It was a way to do sort of an estimation as to how and where profitability is being generated. But this was all done before the electronic health record. And the electronic health record is a game changer because there is a footprint, there is a clear understanding, and there's a clear database of information that tells you how resources are being consumed within the healthcare system. So this new information, this new abundant source of information was not, and couldn't be leveraged through the RVU systems or through the RCC systems. So how it can be leveraged is through activity-based costing. And now you have health systems which have multiple hospitals, 5 hospitals, 50 hospitals within a system. You have multiple specialties where you're trying to understand where resources are being consumed. You have thousands of physicians that you're managing and all the variation that goes along with them. So this is now all about understanding variation in practice. It's about understanding where you have overlapping resources and opportunities for efficiency. So there's a great deal of mythology involved in costing today. So just to criticize my finance colleagues a bit, this is what I call the finance mythology around costing. And the first mythology is we already do this. So when you start to have a conversation around activity-based costing, oftentimes your decision support team would say, we're already doing cost accounting, we're already measuring productivity. Well, not really. They're likely using RVU-based methodologies or RCC-based methodologies. So I'd say you probably aren't doing accurate cost accounting because you can't hold a physician, you can't hold anyone accountable for an allocation or an average. And that's what we're asking them to do. We're giving physicians allocations of costs or averages, and we're trying to hold them accountable, and it just doesn't work. The second methodology is this activity-based costing is just way too complex to implement, or it's way too complex to maintain. And that's absolutely not true. Because the data is in the EHR, it's actually far easier to maintain and to implement than the other methodology. So this is completely a mythology. Activity-based costing is the easiest cost system to implement. And then finally, we have great financial analysis and operations. And all I would say is that you can do much better, because you can't fix what you think is not broken. And in many cases, the current suite of financial analysis and costing products that are available, you actually have things that are, you have issues that are what I call hiding in plain sight. So you can't fix something that you can't see or that you don't know about. So how is activity-based costing different? And why does it matter? So this is an issue about linking things together. So the way that most provider P&Ls work today, there's a physician P&L and there's a hospital P&L. And there's actually, they're maintained separately and distinctly. So, but if you think about that, the physicians who are over here, we maintain a physician P&L, which has their CPT revenues and the cost of the physicians and their staff. And then over here, we have a hospital P&L, which is the hospital inpatient, outpatient revenues, and all the costs and resources of the hospital. But the issue is those two aren't connected. And the people that are making all the decisions around the hospital and the hospital costs are the physicians and the clinicians. So what activity-based costing does is it connects the two. It connects the decisions the physicians are making with the costs that are occurring over on the hospital side. So we're now creating accountability, which didn't exist before. Before, length of stay was free to the physician. The OR time was free. The imaging, the labs, it was all free because it was maintained on the hospital P&L, and the hospital president was made responsible for those results, but the clinicians and the physicians are making the decision. So activity-based costing connects these two, because we know that nothing is free and that for everyone, cost has an impact on consumption. And so what we're trying to do is create accountability and allow our physicians to make decisions based on value, which is cost and quality. So simply stated, what is activity-based costing? I'll walk through this definition with you. Activity-based costing connects the actions and decisions of clinicians to the actual cost of each action and decision. And in between there, I've put related to the consumption of finite resources. But what we're doing is we're connecting actions and decisions of clinicians with the actual costs of those actions and decisions. So it sounds very simple, but it's actually revolutionary in terms of how costs are calculated in healthcare today. So we finally have a tool that reveals the implications of decision-making, of physician decision-making on cost and quality. And to be honest, physicians actually love it. They want that accountability. They want to see the impact of their decisions. They want to be held accountable for it. So why activity-based costing? And our system at Health Catalyst is called CORUS. It's systemic and repeatable. I talked about how easy it was to implement and to use. So this information is available between 2 and 3 days after your financial close. So once your books are closed for the month, 2 to 3 days later, you have actionable information and analytics around your cost and your service line profitability. So it's systemic, it's repeatable. It identifies variation between physicians, between hospitals. It recognizes the physicians recognize their cost profile. So when you hand them a P&L and says, this is what you look like, they say, yes, that's me. It's not an allocation, it's not an average. It's their actual consumption, it's their OR time, it's their length of stay, it's the supplies, the drugs, the blood that they actually utilize. So they recognize their profile. There are no allocations. This is all about consumption, and it's anchored. It's anchored to the general ledger, and it's anchored to the clinical systems. So this next slide is a visualization of that. This is what I call the activity-based costing super collider. So it's a super collider of the financial data colliding with the clinical data from the EMR. So financial data from the general ledger, a source of truth, and clinical data from an EMR, another source of truth. It collides and creates these activity-based costing analytics. So the traditional view of financial reporting is at a standard hospital, they look at it sort of this narrow vertical, just my hospital within my four walls, and I try to maximize my revenue, and I want to cut my salaries, reduce supply expense. I want to try to optimize my physician investment. So I'm looking very narrowly at these functional types of expenses. And I would submit to you that in the new world, it's much more complex. This is about direct clinical costs, which are actually the smallest part of the cost in a hospital. The majority of the costs in a hospital are what I call indirect. Things like surgical services, things like nursing costs, imaging, labs. This is the majority of the costs in a hospital. So we can't just focus on supply costs or drug costs, because they're actually not the majority of where my costs are. I need to understand who's consuming all these resources, not just the direct costs, but more importantly, the indirect costs. So this is what I call the hospital mall, if you will. And the point that I want to make here is that, and you can see in the top left, we have 3 patients that are having the same procedure performed. Let's say that it's a knee replacement. Their care pathway, their journey through the health system may be very different for the same exact procedure. So RVUs and RCC says everybody looks exactly the same. A knee replacement is a knee replacement is a knee replacement. We know that's not the fact. So to the right, you see somebody may come into the hospital through the emergency room. They may come into the primary care physician, and then they begin their journey through the health system. And each journey is distinct and different. I'm not saying that it should be, but there's necessary variation. And we also know there's unnecessary variation, and that needs to be understood and tracked. So we individually need to understand that journey of each patient or that journey of each physician, how they're caring for that patient. So this is what is possible with activity-based costing. So this is the way you truly should look at the operations of a health system provider or a hospital, which is, in this example, by service line. So you look across the top and you see, I have a P&L for my Heart and Vascular Institute, for my orthopedics department, for my neurology department, for my women's health department, and then I can see my results in total. But for each of them, I can develop a P&L which is based on actual consumption. So I know the revenue for that area. I know the direct expenses, as I said, about 30%. And I know the consumption of the clinical indirect expenses, like imaging, like labs, surgical services, length of stay. I can accurately calculate the consumption and assign it to either the service line at the top, or you can substitute individual physicians within a service line. So let's just say for my orthopedic department, I could create the same P&L with physician A, physician B, physician C, and get an accurate methodology that shows the consumption and thus the profitability. So I want to combine the cost and the quality to understand how I'm performing as a health system. So it's a different way of looking. It's the best way, the right way to look at a health system, and can only be facilitated through activity-based costing. So physician variation, as I mentioned, this is an example of how significant on the same type of procedure with these physicians A through H, how different their actual cost is in terms of just supplies in this case. So we see significant variation for the same DRG. And I'm sure there are some examples of acceptable variation, but there is no way it could be this wide and this spread and this different for the same procedure. So this identifies something that what I call is hiding in plain sight. Another example is what I call, and in this example, I think I want to point out 2 things to you. And they're around, first off, this is a lumbar spinal fusion procedure. This example, the N is 852. And I want to show you 2 things. First, the direct costs of a surgical intervention, the direct costs are about 54% of the total, and the indirect costs are about 40%. So on a surgical procedure, about half the costs are still indirect. I also want to demonstrate the tremendous variation that we have. So in the bottom right, you see, on average, this lumbar spinal fusion cost $18,220. but we're able to identify that significant variation between 55% of that average and 155% of that average. And I can only see that through activity-based costing. So I can identify which physicians are the 55% or closer to the average, and those that are much higher than the average at the 155%. And you see that in each of the areas. You see variation on the direct costs of $9,950 between 45 and 162. You see for nursing costs between 53% and 203% of the average. So the point of this is activity-based costing identifies two things: the significant consumption of indirect clinical resources, and also the tremendous variation that's inherent in any kind of medical procedure. This is something that's important to know and to be able to activate and act upon in terms of achieving the triple aim of better costs and better quality. So without these systems, we utilize these traditional ways of margin improvement. Without good information, of course, we can integrate, we can centralize, we can set across the board targets, and that still works, but they're diminishing returns. And you also punish the efficient areas, your high performing physicians and your high performing hospitals and your high performing departments. They get the same across the board target assigned to them, cut 2% of your expenses. So it's done really blindly and a shotgun approach, and that's probably not the best in terms of creating quality and then actually funding areas that need funded. And then the last three are the traditional revenue cycle, just trying to increase revenue. Again, it gets us back to the old mantra of revenue is the savior, and I don't think that's the case. As we all agreed, revenue will never be the same, and volumes will be impacted and rates will be impacted. So this slide says, well, what do we do about all this? Well, what we do is we utilize activity-based costing in a way that's going to allow us to reduce consumption, to reprioritize, to re-engineer our cost footprint. So this is about strategic cost transformation. And one of the ways to do that we started with earlier was around proactive pricing strategy. So the only way to go and enter into a negotiation with a payer is to go into that negotiation actually knowing what your procedures cost, the ability to say this is a premium service versus a commodity service, to understand where you may be losing volume because of your high prices. And if you want to keep that volume and you want to be able to compete against another provider that has kind of popped up in your region or somebody that is considered a lower cost provider, to keep that volume, you may want to lower those prices at the same time raising other prices. So this is about having an actual proactive a la carte pricing strategy where you understand your cost, where you understand where resources are being consumed, so that you can go out and match the value of those procedures to what your payers are paying you for. And so if everybody says that payers will pay for value, this is the way that you demonstrate value. High performance, high outcomes, scarcity of resources. It's a premium service. You're going to command a premium price, and then you're going to lower the prices on the things that are considered commodities to keep your volumes more stable. Service line management. It is impossible to do systemic service line management without activity-based costing. It's just impossible, because you can't look horizontally across the width of your system from hospital to hospital to actually look at a service line, to look at the performance of your orthopedics group, not only from the inpatient services you're providing, let's say at 3 different hospitals, at 5 different hospitals, at 7 different hospitals. What are the high performing programs? Which ones have the highest quality? Which ones have the best payer rates, the best profitability? But then also your outpatient footprint. Where is your outpatient footprint? What are the complements of physicians that you have? So how do you think about a strategy where you're not only considering integrating programs, maybe closing or consolidating programs, but there also may be geographies in your market where you're underserved. There may be an area that's high growth that you didn't acquire a hospital there in the past and you never opened a new facility, and there's a significant opportunity for you to grow market share and volume. So this is all about understanding an external view of your service line, not the internal view. How am I performing at this one hospital? No, you want to understand, how am I performing in the region? How can I maximize volume, keep volume, but do it in a much smaller footprint? The other thing that was very interesting that we found at UPMC is by doing service line management, we were able to give the physicians credit for their supply cost decisions. So when they made a decision around supplies, let's say moving to a lower cost vendor, moving from having 7 implant suppliers to 5 or to 3, by using service lines, we actually gave them budget credit for making those reductions, when in the past, if you recall, I said earlier, there was a physician P&L and a hospital P&L. And so the physicians did it just because they wanted to be good citizens, because they cared about the performance of the health system. But by connecting them via service line management, they now have a financial incentive. If they actually can reduce supply costs, their service line becomes more profitable, or their service line reduces expenses. And that either goes straight to the bottom line, or it allows them to invest in new programs, or to hire new physicians, or to implement new programs. So what I call this is supply cost activation, and it's only really done through service line management, and service line management is really only done through activity-based costing. Clinical practice variation, it becomes a whole new way to activate cost reduction, because you can now look at all of your physicians. The best ones are in the surgical practices because the supply costs are high, but the length of stays are also higher. It's a more intense activity, but you can now identify this clinical practice variation. You can identify best practices, and you want to standardize your practices and your pathways around those best practices. So what it does is it identifies who are your superstars in terms of both outcomes and cost. And again, this isn't just about reducing cost. As a health system, we may want to choose the higher cost procedure if the trade-off is that, again, it's a value discussion. If we can improve value, if we can improve outcomes, we're absolutely willing to invest more and spend more for those higher outcomes, but we need to have the data to make those kinds of decisions around cost and quality. So we want to empower our physicians to reduce clinical variation by letting them understand, this is my profile, this is my consumption, and these are my outcomes. And I'm going to make decisions and I'm going to make adjustments based on value, quality, and cost. So we talked about physician and APP integration. This is a way to think about, how do I deliver care today? Do I have a physician-heavy model? Am I fully utilizing my APPs to the top of their license? So I can change my care model to say, what is my cost per RVU? And can I reduce my cost per RVU by better utilizing APPs, integrating them into a team-based methodology, where now my physicians can do more, they can see more patients because I'm fully leveraging my APPs. So we can calculate through activity-based costing the cost per RVU to really give some evidence and some support towards integrating APPs and physicians to basically increase my throughput and my ability to see more patients and increase the volumes, and at the same time optimize my cost footprint. The other thing I want to talk about is optimization of productivity. So true productivity can only be measured through activity-based costing. I understand the actual inputs and the outputs. So the inputs are costs, and the outputs are things like patient days and the actual volume that I'm pushing through a system. And we're going to show some examples of that at the end of the presentation. But it's also about optimizing the fixed costs that I talked about earlier. So my operating rooms, am I fully leveraging those operating rooms? There's a significant fixed cost, not only for the operating room, but for the anesthesiologist, the CRNA, the nursing staff. And if those ORs are idle, that is lost money, that is lost opportunity cost, and it's a fixed or a sunk cost. So I can measure that productivity by using activity-based costing, and I can optimize my facilities, my exam rooms in the physicians. How am I utilizing the exam rooms that I have throughout the system, both the locations, and are they full, and are they being fully utilized? And then also the significant facility costs that I have, are those being fully utilized. So we have a way to measure and optimize the significant fixed costs of the system. And we also have a way to truly hold people accountable for clinical productivity and now quality. So with that, I think the next we're to another poll question, Brooke.
All right. Go ahead and launch our second poll question. So for this one, we'd like to know how effective are your current cost accounting or productivity and decision support analytics? And we'd like you to think about this from the perspective of operations or physicians in your organization. So your options are highly effective, average, below average, or no one uses it or cares. So we'll give you a couple seconds to respond. Thanks for voting. Give you a couple more seconds. One more. All right, looks like our votes are starting to level off. All right, I'll go ahead and close this and share the results. All right, Rob, so 51% said average, 33% said below average, and then 12% said highly effective, and only 4% said no one uses it or cares. So okay. What do you think of those results?
So, it seems like the consensus is, we have some information. It may be useful in some circumstances, but certainly not something that's driving the overall direction or strategy of the organization. And I think what I've found from my own experiences and from what I talked to other CFOs, there's a significant amount of data that's created. There's a significant level of reporting that's created. And I think it's certainly used and admired, if you will, by the finance team. And it's used by, let's say, the hospital operations team. But where I found the biggest disconnect is with physicians. And it's interesting, with activity-based costing, the physicians become the zealots. They become the evangelists for cost, believe it or not, and quality, because they have information now that they recognize. They're no longer being asked to be held accountable for an average or for an allocation of that 70% of the indirect clinical cost. They have information where they could say, yeah, that looks like me, that looks like my profile. And now they're working hand in hand with the finance team and the operating team to drive better results, to lower costs, to find where those pain points are. We found instances where the physician said, I had no idea that this device cost this much money, or I had no, idea that the length of stay, 4 days versus 3 days, was worth this much in terms of the cost of that bed being utilized by my patient for an extra day. So by empowering the physicians with this information, it actually makes them evangelists, and it becomes a game changer for service lines and a game changer for physician investment. So what I'm saying is activity-based costing is a way to really energize change in an organization. And these historical reports that finance people have created and they take great pride in, and they're voluminous. I think this is a new day in healthcare, and a new standard is to be expected and required for us to be successful against the competition that we have. So the last couple of slides, I'm going to show you just some outputs of activity-based costing. And these are some of the ways that costs can be represented. But very simply, this is a look at, as I said, inputs, which are the costs. So nursing salary is an input. If you look down at the bottom, med-surg days are a volume output. Surgical services salaries are an input. The OR operating room hours are an output. Provider cost is an input, the cost of my physicians and the APPs. And the WRVUs are an output of volume. So I'm comparing the two and I'm saying, what is my cost per? What is my cost per RVU? What is my cost per med-surg day? So this isn't talking about direct hours. A lot of this it becomes self-fulfilling when you say, well, this is training time. My nurses were in orientation or they were in training. Well, those are costs of doing business. Training is a cost of turnover, which is a direct result of the management of that nursing unit. And so there's a cost involved with that. So you can't pick apart and pull out things and say that they're not applicable. You actually have to look at the costs from the general ledger and the volumes from the clinical data to say this is true cost productivity. So in this example, if my volumes are down in nursing, if volumes in med-surg days are down 1%, and my expenses are still up by 2%, well, guess what? My cost per med-surg day went up 3%. So this is what I'm saying is true productivity. If you look at supplies expense, the expenses went up 4%, but the adjusted patient days were only up 1%. So again, this combines volume and cost, input and output, to show me my cost per. And it's a way to measure how I'm performing versus the prior year, and it's a way to show my trends. But this is true productivity, which is linked into the general ledger and to the EMR. And you can go ahead, and there are all kinds of case studies and examples of how I can do this at lower levels, look at individual hospitals, and I can look at trends. So there are thousands of different ways that you can cut this data. So just a couple of summary slides before we move on to any questions that you might have. This is just saying, how do you win in today's environment? It's through a new way of looking at your results and your operations. It's through service line management. It's creating collaboration and physician engagement. Physicians are key to reducing costs and improving quality. And the only way we can get physicians engaged in cost productivity is if they actually believe in the costs and if the costs are accurate. And you can't do it with RVUs, you can't do it with RCCs. You need true consumption, and the only way to do that is through activity-based costing. So that is really the key to winning in this new environment that we're in. And then finally, a bit of a discussion around the CORUS product that Health Catalyst provides and what the value proposition is. So again, it's much better analytics than are available in RVU costing. So this is looking at 100% of clinical costs. There are no allocations, there are no averages. This is the actual consumption that's going on by the clinicians. The ease of maintenance, it's very easy to implement, and it's very easy to maintain, much easier than RVU-based systems and much easier than RCC-based systems. This can be implemented within 90 days, actually, because all the data is already available in the EMR. And then we suggest to run another 3 months of user acceptance testing. So within 6 months of the start of implementation, you can have an activity-based costing system up and running. And again, it's very cost-effective in terms of what you're likely paying for your current decision support systems or your current cost accounting systems. So that is the formal presentation, and I would love to hear any comments or questions that you might have now.
Great, thanks, Rob. As Rob mentioned, please go ahead and submit your questions in the GoToWebinar control panel, and we will start answering those in just a moment. We do have one more poll question for you today before we start our Q&A. While today's webinar is focused on operational and cost transformation, some of you might want to learn more about Health Catalyst products and services. So I'll go ahead and launch this poll. So if you'd like to learn more, please answer this poll question, and I'll go ahead and leave it open for just a few minutes while we start our Q&A. Okay, so Rob, looks like our first question comes from Jim. And he says, it sounds like what we're talking about here is some serious downstream disruption to make the delivery of care more efficient. I see Walmart and CVS, etc. mentioned, but what about physician house call models like Heal? Would they be on a tier with these other downstream disruptors?
Okay, can you repeat, Brooke, the name of that organization?
He didn't, I don't have his organization. His name is Jim.
No, I'm sorry, the disruptor that he was mentioning specifically.
Oh, Heal.
And it was physician co-location?
Physician house call models.
Oh, okay, thanks. No, I think, and actually one of the examples, Alignment Healthcare, is very much like that. They're focusing on the Medicare Advantage population. Again, chronic conditions, how do you keep them healthy? So absolutely, the insurers are saying, look, primary care as it is today is not working with seniors. Let's go to them, and I can invest in that delivery of care because I'm going to save money downstream. So absolutely, what they're saying is that I've got an older population where I have a higher percentage of my volume, of my inpatient volume specifically. If I can keep them healthy, if I can keep them, and that's the exact model for for Clover Health and for KenMed and Oak Street Health. They're focusing on that high utilization population. So these are all disruptors, and the way to compete is basically I've got to be able to provide value in the relationship that I have with that primary care physician, but also the ease of access. So when you think about scheduling an appointment, whether it's a virtual visit, that senior has to be able to actually see that physician. They can't wait a week, they can't wait 3 days, 2 days. They need to have a modality to have access to care. So it may be with immediate virtual visits, it may be with a commitment to have 24-hour patient access. These are the very significant, as you described them, downstream disruptions that are needed. The providers have to disrupt their business model to compete in this world, because the competitors are, again, highly funded and highly aggressive in terms of their goals, and they're answering to investors. They're making promises that they're going to disrupt, that they're going to capture market share, and that's what the entire investment thesis is built around. So I view this as a significant threat, and it is going to require significant changes to downstream operations to make us as providers formidable or even reasonable competitors to these new forces in the markets.
Perfect. Okay, we'll go ahead and do a next question. Comes from Susie. Are patients continuing to delay healthcare based on concerns of contracting COVID-19? And when do we anticipate this hesitation will subside? What long-term impacts will delays in healthcare have on the care delivery system, especially for chronic care health conditions requiring regular engagement with a physician, such as hypertension, heart disease, diabetes, etc.?
So probably the last person you want to ask that question to is a finance person, but I'll answer it anyway. You want to ask a clinician that, but I think absolutely it's going to impact the health of the population downstream. There's one school of thought that says there's actually some unnecessary utilization that's going to go away. I had lower back pain. I couldn't go in, or I was afraid to go in and get it looked at. I did rehab, or I did nothing and it went away. But I think what you're going to have more of is you're going to have people that didn't get their colonoscopy, didn't get their annual physical, and with serious implications later that could end up with cancer that was undiagnosed, or heart condition that was undiagnosed. So they're absolutely going to be not only costly but tragic outcomes to this lack of elective care and primary care during COVID. And I think we'll work some of that volume back when things clear up. But again, I'm not sure that it's ever going to go back. These new modalities and these new competitors will have very valid and competitive offerings that will challenge the current business model.
Perfect. Okay, we'll do a couple more questions. If you have any, please submit them. We've got a couple more minutes left. Next question, what are the biggest roadblocks in terms of implementing activity-based costing?
Actually, the biggest roadblocks are oftentimes the decision support departments, part of the finance groups, because they are well established. They are creating, and this isn't all, this is just an example. They are creating RVU-based cost reporting, and they are protective of it. They're proud of it as well. They should be. It's something they've worked years on. But we've often found physicians will come in and say, look, I don't use this data that you're creating. The finance department will use it. The CFO may use it. The hospital president may use it. The physicians aren't using it. They don't believe in it. They disagree with it. They attack the methodology. So, we'll come in oftentimes and the physicians are saying, look, I want to learn more about activity-based costing. I believe in this. I can get behind this. I recognize my profile. I want to have a better practice of medicine. And the roadblock sometimes is to say, well, look, we're already doing this cost accounting. Use these reports instead. So I think it takes executive leadership. It takes sort of from the C-suite, CFO, the CEO, maybe the hospital presidents, and the physicians, those that are leading service lines or the physician executives, to say, wait a minute, we've got something here. Yes, there's a lot of tradition behind the cost accounting that's used today, and it's a well-established system, but there's a new way of doing it. We have a wealth of information, a treasure chest of information from the electronic health record that we're not even utilizing to do costing. So this is a chance to truly get to the triple aim of cost and quality. So that's the biggest roadblock, and the way through the roadblock is to engage the physician executives, the C-suite, and that's how you kind of break through some of those roadblocks.
Great. Okay, next question. Have you found pricing built into EMR orders impacting cost and quality savings?
Say that one more time. I'm sorry, Brooke.
Oh, that's okay. Have you found pricing built into EMR orders impacting cost and quality savings?
I don't know that EMR data in terms of cost is always viewed as reliable. And what we found from implementing activity-based costing, we will find some cleanup that's needed in the EMR. Actually, it helps in terms of hygiene in the EMR. I'll use one example around exam room utilization. There is a timestamp that is available in Epic, for example, where you can see when a patient actually went into the room and exited the room. And if you want to rely on that in your costing system, well, theoretically, the information is available in the EMR. But we found in some cases there may be individual practices or certain parts of an organization which isn't maintaining that timestamp accurately, and they should be. So it helps actually by finding the anomalies in the costing information, we're actually able to better leverage and improve the EMR information by connecting the two of them. So it's really a symbiotic relationship between cost and quality, where we're going to rely on that EMR data, and it helps us to ensure that it's reliable, that it's accurate, and more systemic in its upkeep. So there's a real synergy there.
Great. Okay, next question. Is your system language agnostic? Do you use both structured as well as unstructured data?
It's primarily with structured data. I don't know that there are capabilities to use unstructured data, but and it's sort of walk before you run. There is so much structured data today that is never utilized in costing systems at all. And again, this is the EMR data, which is structured data. So we're walking before we run. We're utilizing this wealth of structured data that's available that tells us exactly what's happening with the patient. It tells us exactly how resources are being consumed by clinicians. So ultimately, we want to leverage all the data that's available, the unstructured as well. But for the time being, we have literally years of analytics and consumption of interesting and life-changing and business-changing structured data that's available to us to utilize in a costing system.
Perfect. Okay, looks like we might have time for one more question. So this question says, we are a successful academic medical center with great brand reputation and market share. Do you really believe the urgent care sites and drugstore locations are a threat to our business model?
So yeah, this is one, I hear this all the time. Like, look, we're hospital ABC. We have people coming from all over the world to access our care. So absolutely, if for neurosurgery, for the emergency room, for the inpatient stay that are required, that academic medical center is going to continue to have both the reputation, but also the results of always getting that care, delivering that care, not losing the market share to the CVS store down the block. However, if you remember that first slide, this entire balkanization that's happening, we don't need to disrupt 50% of revenue to impact the bottom lines of that successful academic medical center. A 5% impact of revenue, a 3% impact of revenue, with the significant amount of fixed costs, it falls straight to the bottom line as a negative. So what I'm saying is that, yes, you are an academic medical center. You are going to be, to some extent, immune or buffered from some of this activity, but certainly not all. Because the Medicare Advantage disruptors, the insurers, they will start steering some of this away from you, whether it's imaging, whether it's labs. They will provide incentives to seniors to make decisions to say, well, I go to the AMC for this service, I have to pay co-insurance or a copay. If I go to this low-cost provider, it's free. And that is a tremendous incentive for somebody to go to an alternative site of care. So you're going to be somewhat buffered or immune, but not totally. You will be impacted no matter.
Awesome. Okay, I'm going to sneak in one more question, and then we'll go ahead and wrap up. The question says, given the typical data quality, data integrity, and data integration issues within a typical healthcare facility, how long does it take for this methodology to become mature?
How long does it take to become mature? Well, let's again walk before we run. Literally in 6 months, you're going to have actionable data that is going to start raising questions, things that were hidden in plain sight, things that you viewed as a fact that you will find is a fallacy, that you weren't measuring accurately, or that you were measuring the wrong way, or the data was actually giving you the wrong answer. So you will have actionable data that will drive discussions and debates and clinical changes immediately. When does it mature? I think the answer is never. Like, this is always a continuous thing. It's a continuum. Data continues to, you recognize data where there's not good hygiene around the EMR data, and you fix that, and you should have fixed it anyway, and it actually may have another benefit to fixing it. So it improves operations, it may improve safety, it may improve clinical outcomes. But, you know, in terms of maturity, I don't know that anyone's reached full maturity of activity-based costing yet. The systems that have implemented it are sometimes 2-3 years on their journey, and even today finding new ways. So this is a journey, but I will tell you that the improvements and the actions are almost immediate after the 6 months implementation, and we're all on our way, I think, to maturity.